Well, Mark, thanks for allowing me to interview you, particularly at this time. Just to give it context, so I'm interviewing you on the 23rd of November, and I think that's just important because people might be looking at this infocast in the next few weeks. So just to context it, Mark, I know you, but could you just introduce yourself, one from a pulmonary hypertension perspective, but also we're going to be talking very specifically about the news at the moment about vaccine in the future. So could you just introduce yourself, Mark?
Sure, no problem. So I'm Mark Toshner. I'm a university lecturer in Cambridge, and I work in Royal Papworth Hospital, where I'm a consultant in the Pulmonary Hypertension Centre. And my background is really in research. Some of your listeners and viewers might have met me on some of the roadshows, or might have been involved in some of the trials that we've helped run. And so I'm particularly interested in running clinical trials on pulmonary hypertension. So that's my kind of area both of interest and of passion. And I've become an accidental vaccinologist. This was not
is that a word, Mark? Is a vaccinologist the word?
It really is. No, it's a word.
Right, good.
It's a word. And the reason I got involved was because they essentially needed a doctor who had experience of running clinical trials, and I just happened to be the person that for whatever reason it was decided they wanted to work with in Cambridge. So I've ended up helping to run the Oxford vaccine trial, and I've recruited about 300 participants from healthcare workers in Cambridge, and I've been involved in that since the very start of the trial.
Okay then, Mark. So as a vaccinologist, a really simple question: what is a vaccine?
So a vaccine is any substance now, and it used to be largely related to the viruses themselves, but it's now substance, and we can come back to that later, that helps provoke your immune system into responding to a pathogen. I mean either a virus or a bacteria that can attack you. And then what happens is your immune system recognizes, develops a defense mechanism against that pathogen, and then goes into hibernation, ready to spring into action at a later stage if it ever comes across it again.
Okay, so our immune system is that fights infection.
That's right, yeah.
Basically. Yeah, and so it's getting it ready. Okay, so vaccines are not new, are they? They've been around a long time. Are they?
Yeah.
We're not talking about the COVID vaccine, but vaccines per se. Just give some sort of history so we know where they're coming from.
A couple of centuries, yeah. And in fact, vaccines have got a very strong case to be made for being the single most important advance in medical research in its history, and are probably, along with clean water, responsible for more lives saved than anything else on the planet. Okay. So vaccines have this long and pretty glorious history of protecting us against infectious diseases, or predominantly infectious diseases.
So I know this is a really broad question, Mark, and again, we're talking general at the moment. How long would it normally take to develop a vaccine?
So the figure being bandied about right now is about 10 years, but it's a false term, it's a false time frame. And it's a bit like in pulmonary hypertension, actually. So in pulmonary hypertension, if you look at the drugs that we developed, 10 years happens to be about the time frame that most of them took to be developed. And actually, that's for the very same reason that vaccines take 10 years. Most of that 10 years is spent doing not very much. And that's not because someone like me is lazy. I work pretty hard, or at least my wife will tell you that. But I spend a lot of time trying to convince either funding agencies or drug companies to invest in therapies, and then trying to get them through the regulatory process, and then trying to find volunteers to then sign up to the trials, then going through all the kind of boring process of running a trial, often on a budget that's tight. And at the end of all of that, if I'm really lucky, I go back to the regulators again, and then there's another big long delay while the regulators cogitate.
Who are these regulators, Mark? What is a regulator? These people that allow you to get a license for the product, or what do they do?
That's absolutely right. So the regulators are the bodies that decide who and what can be given to human beings. And so in the UK, it's called the MHRA. and the famous one in America is the FDA. So these
What's
are the
that
people.
for, FDA?
The Federal Drugs Agency.
Yeah.
Federal thing, yeah. Let's hope that's
just
right.
a check. It's a test. It's an exam. Yeah.
So these are institutions that are set up to try to make sure that drugs and therapies that make it into human beings are as safe as they can possibly be, and that there's a framework for following that safety up even when they are in general use.
So these are people that are independent of people like yourself and drug companies. They're
completely independent of ourselves, independent of government. They have their own, structure of governance.
Okay, so if that's the norm, now coming to the present day in COVID-19, and one of the concerns people have genuinely, and it's sometimes due to media, sometimes to social media, is that this vaccine seems to have rushed through those processes. Yeah. Is that, and is it safe?
So I hear that word a lot, and it's the wrong word, because it does make it sound like there might be a degree of changes in our normal safety protocols. And that's just not the case. I can be absolutely unequivocal about that because I was involved in the trial. And in actual fact, I've been astonished by the level of regulatory oversight and the reporting of safety in vaccine trials. And it's made me rethink some of the trials that I run in pulmonary hypertension. So I'll just give you a little example. In pulmonary hypertension, the last trial I had recruited less than 30 people. And there were 4 serious events in that trial. Now there were no lasting consequences of any of those events, but an event and how you record an event, an event might actually not be particularly worrying, but for example, if someone is admitted to a hospital overnight, that becomes an event, even if there's nothing wrong with them. Okay, so that's a bar to make sure we're not missing anything that might be serious. So that's 4 in a trial of 30 patients. And I would not classically stop my trials because of that. That's actually a normal proportion for the sort of therapies that we work in, and judged appropriate because pulmonary hypertension is a serious disease that's life-threatening, and therefore the risk versus the balance has to be considered, the risk versus the benefit. In the vaccine trials, hundreds of thousands of people were being vaccinated. And we were reduced the media were reduced to reporting single events. If you think back to that one event, that neurological event, we were talking about one event. Trials were completely suspended until those single events were poured over in great detail. Okay. It's a bit like if you were to take Sunderland and watch every single person in Sunderland for medical emergencies and report every single person that was admitted to hospital, every single person that had a heart attack, every single person that had a stroke, every single person that had a cancer, every single person who had a neurological event. We'd be doing that hundreds of times a day. And so in some ways, it is astonishing that we were reduced to talking about 1 or 2 or a handful of individual cases.
Do you think that's because of do you think some of that is the spotlight is actually focused on this? So there's nothing unusual. The unusual thing is the spotlight. Everybody's watching your waking breath at the moment. Yeah,
but in actual fact, they didn't have much to watch. And that just goes to the safety of vaccines. Vaccines have an amazing safety record, in particular compared to drug therapies. And I personally am very comfortable and will be first in line to have a vaccine the minute I possibly can, because of that historical record, but also because I know that the trials have been run safely. Now, what they have been done is they've been run quickly, which is not the same as rushed. And the reason we've been allowed to run them quickly is because effectively we were given money, and lots of it, and that's important, but it's not the only thing. We were also given the whole of the world's trials infrastructure. So every single unit in the world that considered running a vaccine trial was able to utilize all of its staff that it wanted to. So I had 90 people working for me at one point on the ChAdOx trial.
And how many staff would you have on the study that you said you got 30? What would the number equate to that?
So to run the trial, and we were the sponsors of the trial, so we were the kind of central coordinating hub, we had 4. I was one peripheral site and I had 90. If you could just imagine how many people Oxford had running on it, there were hundreds of people across the UK working 16 hours a day in this trial. And that is another reason why we were able to run it so quickly. Probably the last reason, and possibly the most important, is that there are some amazing altruistic people in our country. And so when we asked for volunteers for an experimental vaccine study, and at that point, we didn't know if there was going to be any safety signals because we hadn't run the trials. Tens and hundreds of thousands of people put their hand up and said, I'll do that. So the very best of us across the country put their hands up and said, I'll be first in line for a vaccine that hasn't yet established its safety. And they did that so that you don't have to. So all these normal barriers that I have in my everyday frustrating life in clinical trials just melted away. And the analogy I use is it's a bit like sitting in traffic in the middle of London or in Glasgow, and somebody just clears all the traffic away, turns all the lights from red to green, and then gives you a police escort. So it's not that there was any compromising of safety. In fact, the safety reporting was, if anything, of a higher standard because of the scrutiny we were under. But all of those usual real world frustrations just melted away, and we were able to run what in effect, was a dream trial from the perspective of somebody who's involved in it.
Good. Which is really, that I think that's very reassuring, because there's been a global response here as well, hasn't there? So nobody's been operating in isolation. That's another significant thing here.
It's really important, Ian, and you're right. And in fact, even our trial, which reported today, and I guess we haven't talked about that, but the timing of this interview is amazing because we've reported the results of it literally several hours ago. So this is hot off the press, but that includes patients from Brazil and South Africa. So this was not done in isolation. This was done as part of a coordinated effort on the part of clinical trialists and researchers across the world. And I think we're going to look back on this last year and we're going to call it our finest hour, because and we had some luck, because there was some luck at the timing of this. If this had happened 10 years ago, there's no chance we could have got to where we are right now, because some of the preclinical science, some of the basic science that was needed to be able to understand the genetic code of the virus and to then translate that into possible vaccines and treatments, we couldn't have done that. The computing power just wasn't there. So we got a bit of luck. We also got a bit of luck in that some of the candidates for the vaccines were just at the right point to be trialed in human beings. But what we really did was rapidly turn that kind of basic science, that fundamental science, into something practically useful for people. And so I expect this to be a period in my life that I look back on with great pride, to have been part of something that was frankly astonishing, and that the world should view as an unequivocal positive story. Science has come to the rescue, and I'm very positive about the next 6 months. I think we have a light at the end of the tunnel to look forward to.
Yeah. I mean, I remember, I don't know how long ago, and it's not a political comment, but I do remember Boris Johnson saying some time ago, the change will be when the science equation is in our favour. And it's time that takes it. It's interesting, Mark, to hear you say this happened at a fortunate time in the middle of a pandemic. It's been difficult to see anything fortunate, but this news is really good. Do you want to tell us something? I mean, as you say, the clinical trial that you're involved with is reported some sort of data today. What are the crucial bits, Mark, the headlines for you and to the people with pulmonary hypertension, and generally at large who might be listening to this? What's the headlines?
Okay, so I'm going to give you a slightly more nuanced than I think is being reported understanding of trials, but I'll try not to go into too much detail because I can get quite geeky in this sort of stuff.
I'll tell you not to. Don't worry.
So there are two important things really that we look for from a vaccine to COVID. One is, does it prevent severe disease? Because that's the thing that's leading us to have to lock down the whole of our country. It's the fact that people are dying, and people are dying in very high numbers. And if we don't lock down the country, then we overwhelm our NHS, and we will have many excess deaths. So you want a vaccine to prevent severe infection, you also want a vaccine to prevent transmission, because if we can prevent severe infection and transmission, then that's the quickest path to us getting back to some sort of normal. And the short answer to your question is that we now have evidence in our trial that the Chaddox vaccine does both. There'll be a lot of focusing on the percentages. The headline figure for the Oxford vaccine is that it prevents 90% of symptomatic infections at a 2-dose regimen where you get a lower dose and then a higher dose. But this is early data, and it's early data really in all of the trials, and it will be a changing space. That headline figure is amazing, but it's not the be all and the end all. The most important two things are going to be, do we prevent severe infection and do we prevent transmission? One of the good things about the Oxford trial, which is slightly unusual about it, is that we were surveying weekly all of the participants in the trial. So we have very good data on asymptomatic carriers, which is the one big worrying reservoir for the infection, because you can't, it goes up. And it looks like we have early promising data to suggest that we prevent that. So we've got good data to show that we prevent severe disease, good data to show that we prevent symptomatic disease, and some data that really excitingly suggests we also prevent asymptomatic disease. So it's really been an astonishingly exciting day and an amazing thing to be part of.
One of the phrases you used a few times there, Mark, is early data. What does that mean? Does that mean it's early in the trial? I mean, what would be, what does that actually mean?
So that's a great question, and that's another thing that keeps coming up, is people are worried about safety and how short a time frame we've run these trials in. In the Oxford vaccine trial, we have thousands of years worth of patient year data. Okay, so what that means is if you add up all of the safety data, and in each individual patient it comes to thousands of years worth of safety data, which is something that in pulmonary hypertension we never get. It's safety data over around about a 6-month period, and that's usually the time frame of, in fact, I can't think of a single complication of a vaccine that hasn't emerged over that time frame. But we're talking about risk here, and you can't state confidently something that you haven't observed yet. So we still don't know about long-term effects. History tells us that there are vanishingly rare side effects to vaccines in the long term. So I think we can be confident from previous evidence from all vaccines, in fact, that it is unlikely that we'll have rare long-term events, but we can't say that without having watched it. But I don't think anybody would sensibly sit and say we want to wait 10 years before we use this vaccine because we're worried about rare events in the long term.
Okay.
And we can be confident that when the data is published, we will have a very large accumulated body of safety in the right time frame, which is within the first 2 to 6 months after a vaccination. And the reason that's important is because vaccinations, and the reason vaccinations have such a short time frame of side effects, is because you only give 1 or 2 doses, and those doses have a short term effect. Once you've had your immune response, the attenuated live vaccine in our case is dealt with by the body, and it's not sitting in the body anymore. So that's why you don't tend to see long-term effects with vaccines. It's because their mechanism of action is all very short-term. So
right, okay. One of the things we've also said, and I've sort of picked this from the media and things like this, is that we've tested this vaccine in healthy patients, healthy individuals, and that's people who have put their hand up and said, I'm willing to go through this vaccine. How confident can we be that in people like with pulmonary hypertension and other issues that it's as safe in those people?
Okay, so that's a great question. And I think no vaccine has ever been specifically tested in a pulmonary hypertension patient population. Mm-hmm. And in fact, you'll find that for most disease processes. Pulmonary hypertension doesn't have a very strong immunological basis unless you're looking at connective tissue diseases. One of the risk groups that we worry about are immunosuppressed patients. And some of our patients are immunosuppressed. So for example, if you have something like scleroderma, you might be on a drug that dampens down your immune system. And that is a subgroup where we have caution. But the good news is we have a number of different vaccines that work in a number of different ways. So for example, the Pfizer vaccine and the Moderna vaccines we have no reason to suspect that in immunologically compromised patient populations, there's going to be a safety issue, because you're not dealing with a live virus, you're just dealing with a little bit of
Okay.
RNA. That's the message that translates DNA into proteins. So I think we've got a suite of potential vaccines that will be suitable for a lot of people. How well they will work, for example, in someone that's immunocompromised or is on immune suppression, is a different question. Mm-hmm. So the question of how well they work is separate to the question of how safe they are.
Yeah.
However, what we just need to do is we need to get to a point where we reduce the prevalence in the population. So actually, even if you don't get a vaccine, as long as enough people do get vaccines, we'll get rid of the disease by herd immunity. So actually, not having a vaccine in itself isn't necessarily a problem, as long as we get to the point where there's, so little virus about that your risk is dramatically reduced.
Okay. These different names of vaccines are often named after the drug companies, aren't they? That's the difference. And it's important. I think one of the things you said there, that we have a suite of vaccines that are available, because this is a global issue as well. I mean, obviously we're speaking in the UK, but this is a global issue as well. A big question, when do you think the vaccines that we're talking about would be starting to be rolled out? Is there a timescale at the moment? Is it just too early?
Yeah, so that's obviously the $64,000 question. And I expect vaccines to be rolled out in the UK in December.
Right.
So it might be the middle or the end of December, but assuming the regulators license them, and the two things they will be looking at are, do the vaccines work? And we now know that the answer to that is yes, and the safety of them. And that'll take them a little bit longer to go through with a fine tooth comb. So they're not going to do it in 24 hours. It will take them weeks. But once, and every indication is that we will have 2-3 licensed vaccines rubber stamped by the regulators by the end of the year. Once that happens, it's then about the practicalities of administering them. So I'm expecting Rollout to start in December, but it's going to be focused on healthcare workers first, healthcare workers and elderly people, because they are highest risk.
Healthcare workers, because I've seen some criticism over the weekend about why are they getting it first. Is that because they're more at risk of the infection, or because of the nature of their work is to provide protections until this sort of vaccine is rolled out?
I think it's a combination of the above, and if you think about it, it just makes sense. One of the highest risk places in the first wave to be was in a hospital. So if you want to reduce transmission, it's a great place to start. Healthcare workers had many-fold greater risk of getting the virus and of becoming unwell because of it, just because of the numbers. So in Papworth, I looked after patients on the intensive care, and about half of those patients were healthcare workers, sadly. So my colleagues literally were rocking up every day and putting themselves right in the line of fire. The last reason is that it's critical that our healthcare infrastructure is able to cope with the pandemic. So to be able to inoculate our healthcare system and make it as robust as we can, it's the logical thing to make sure they are vaccinated first. So for these 3 reasons, I think they're a very good place to start. And the government is planning to start also in the high risk and vulnerable populations, in particular in the elderly.
I don't know if you can answer this question as well, because I wouldn't even know where to begin. Once you've had the vaccine, when is it effective? Is it effective? You've had the vaccine. Are you protected from tomorrow, or?
So now you're getting information that isn't widely available, but it's a period of weeks. So you don't get protection immediately, and the best protection in all of the studies so far has been afforded by getting a vaccine and a booster. So that's a period of usually 4 to 6 weeks. Now, at the end of that period, you are pretty effectively protected against getting coronavirus, and it's not a binary thing. It's not a no protection, sudden protection. It's a gradual thing. So your protection increases over those weeks. However, it takes up to about that time frame for you to be at the full effect. So it's not a case of we're just going to vaccinate everybody and then in 4 weeks later life gets back to normal. That is not going to happen. This is going to take months for us to eat into the proportion of patients out there, or participants, or subjects, or people who are at risk. And it's going to be a little while before we are approaching normal, but you can now see the route to it. You know, we can see our way out of this, and it might not be quite as quick as people are hoping for, but it's going to be next year.
Yeah, I mean, I think it's interesting, 9 months into this, that, you know, actually it's this light at the end of the tunnel, that there is a route in this, and I think that's what's the most exciting thing about the news in the last few days, and particularly today. You've mentioned, Mark, the sort of most vulnerable and the elderly. One of we know in pulmonary hypertension, sadly, is a condition that affects children, and there's obviously you know, huge questions around that. Would they be classed as vulnerable? And are vaccines ever tested in clinical trials in children?
So that's a super question. They are almost never rolled out to children first, because of obvious and understandable anxiety about children being prominent in a first wave of experiments. So nobody really has data yet on studies in children. That will be planned next. But I think there's a very good argument that the children are the least of our priorities right now, because they're both not, they don't appear to be, from the evidence, a big reservoir for infection. So most of the transmission appears to be happening not in schools, for example. That is the current state of our knowledge anyway. That may change in the next few months, but so far the international consensus is that children are not a strong reservoir for the virus circulating through communities. The other thing is that they are also, thankfully, the lowest risk group. Now, that is not that they're zero risk, and we've all heard the reports of rare children becoming very unwell with the vaccine, so it's not that we underestimate that, but in the hierarchy of who we are worried about, they are very close to the bottom. And because they will not have had the vaccine tested in them in the first wave, they will not be vaccinated until much further down the line, once we've proven it's safe to do that. And I think they'll come towards the end.
And can I just be clear there, Mark, that because you talk about children per se, what about children with really serious conditions like pulmonary hypertension or cystic fibrosis? Would they be seen any more of a priority for the vaccine, maybe?
So I don't know is the short answer to that, and that will partly depend on how the trials evolve. We haven't seen big reports of excess deaths in pulmonary hypertension patients, either actually not yet convincingly, certainly in children, and perhaps not yet in adults, although that is a much more controversial area. And it's hard in pulmonary hypertension because it's obviously not a common disease to get to the point where you can be really confident that your observations are correct. And it's complicated by the fact that a lot of our patients were shielding. So we think some of the decompensation, or some of the sickness we saw, and perhaps even deaths we saw over the time from the lockdowns, were actually just related to patients not being able to get access to full care, rather than necessarily lots of patients having COVID. Okay.
Again, a common question that's coming from our membership, Mark, is vaccines, and because obviously many of our people that it's our privilege to look after with pulmonary hypertension, interactions with other drugs. Do vaccines tend to interact with other drugs? And a common one, a very common question over the weekend, things like anticoagulation, warfarin, and things like that.
Great. So that is a good question. So in fact, it's a really excellent question. And the answer is actually no. So there's a reasonably simple answer to this. There are very, very rare instances of vaccines having been demonstrated to interact with any medications, in actual fact. There was one instance where, after a flu jab, the swine flu jab a number of years ago, there was an excess of younger patients getting narcolepsy. It was rare. So it was in somewhere in the region. Actually, the original report that outlined it was from Papworth and a friend and colleague, John Schneerson. But it was in the region of 1 in 50,000. So we're not talking common effects here. We're talking very rare cases. And some links have been made to a protein involved in narcolepsy, and so there's a kind of plausible mechanism there, but not drugs. So vaccines very rarely interact with anything else, but they do occasionally. So it's important that we're honest that vaccines are not without any risks. But then again, very few things in life are. You could argue that climbing up a ladder at work is demonstrably less safe than having a vaccine, that crossing the road is less safe than having a vaccine. We continually, as we go through life, evaluate the risks of things around us. Sometimes we're good at evaluating that risk, and sometimes we're not so good. So for example, there are people who are scared of flying but who will get in a car, you know, and they're getting the risk balance wrong, but that doesn't mean for them that's anything wrong. And there are people who feel the same way about vaccines. So a lot of people have anxiety about vaccines, even though their track record is you know, higher than many of the drugs they're on. Yeah. And I acknowledge those fears. Those fears and those concerns are real, and they're appropriate, and they are to an extent stoked up by the media and have been over the last couple of decades. For those people, I would say, you don't have to jump into this. You've got months to think about it, because you're not going to get offered a vaccine next week. You know, you're probably not going to offered a vaccine next month. Go away, read the literature, read about the side effects. If you need to get counsel, come and speak to somebody that you have confidence in, and you don't have to jump.
There's a really good point there, Mark, because you can read lots of stuff, you know, Dr. Google, etc. And that's no criticism of Google per se. Please don't sue me, Google. How can, as a, you know, a highly respected healthcare professional, how would you describe to somebody, this is how you check the quality of the information that you're reading? Because you can just, you know, what quality of information?
And I think that's a really, really good point. So the first thing is, try not to take your information from social media, because that is not a good source. If you are able to and wish to, go to the source literature, so go to the actual papers that it's published. If you feel that's a level above what you're comfortable with, go and find somebody who you trust, who is expert in being able to understand that literature. And the good thing about most of the pulmonary hypertension cohorts that we look after is that they have a high degree of trust in us, and we know this because, you know, the PHA has done work on this in the past. Yes. You have an incredibly close relationship with the teams that look after them. Go and speak to them. They're a good source of high quality information, and will be able to address any of your questions. And hopefully your relationship with them will be such that you won't feel you're being pushed into anything, that you're just being given information to help you get to a decision that you're comfortable with.
Mm. I meant to ask this question right at the beginning, actually, Mark, or near the beginning, about the vaccine, because it's quite common. Are vaccines, and excuse the simplicity of this question, so the COVID vaccine, is it a small amount of COVID that you're giving to somebody and then they develop a response, or is it something else? And forgive me for what sounds like a really ignorant question there, but are you giving somebody a bit of COVID?
And it's really not an ignorant question, because sometimes that's what we do with vaccines. We give a live attenuated version of the vaccine. The word attenuated just means the virus or bacteria has been changed so that it doesn't multiply. So you basically get a low level of exposure to whatever the pathogen is, and then you develop the immunity, but the pathogen's been weakened and it can't cause illness. But that's not the case with all of the COVID vaccines that have been developed so far. And so some of them have taken some really novel approaches to this. The two ones from Moderna, BioNTech, and Pfizer have used a completely revolutionary new way of doing it, and it's just to basically to code for the bit of RNA. RNA is the piece of genetic material that the DNA produces to make protein, and we're doing this all the time, so it's a perfectly natural process. They just directly give you that little bit of message and fool your cells into making a protein that the virus expresses on its surface. So it's not, you're not being exposed to a virus, you're just being exposed to that one protein that the body then recognizes. And it means that when a virus attacks you, your body already has a preformed defense mechanism to the major bit of what the body sees on the cell surface, or on the virus surface rather. So it's a really clever way of provoking a response that you then hibernate and will be able to, reactivate if needed without actually giving a whole virus. In our case, in the ChAdOx trial, we've used a different method, and that's to use a kind of cold virus and then re-engineer it so that when it goes into your cells, it then does the next step of making your cells produce that protein. So it has the same effect, it's just a slightly different way of doing it. And other vaccines have taken a different approach of maybe engineering the protein and then adding in some what are called adjuvants that basically provoke an inflammation reaction so that your body then does the same thing. So there's a number of different ways to get to the same end product, which is the body having recognized a bit of the virus so that if it ever comes in contact with it again, it can immediately react to it and destroy it.
Mm-hmm. Good. That's helpful. I just didn't quite understand that before, so that's really helpful. What I think we'll sort of tie this up now a little bit, Mark, but one of the really common questions is about vaccines, and I hear it from my colleagues as well at work per se. When I ever have the flu vaccine, I always feel a bit rubbishy afterwards, so I'm not going to bother, and when I say rubbishy, maybe for 2 or 3 days a bit groggy and things like that, my arm hurts, so I don't have it. And what would your, again, what would you say to that?
So I get that, and so I always now have the flu vaccine on a Friday because I always feel terrible for 24, 48 hours, and after, and I'd rather not have to come into work feeling rotten and achy, and it always gets better. It lasts 24 to 48 hours. I recover and I just crack on with normal life. I think that I understand that because I get it myself, and you'll probably, the odds are you'll get some symptoms because that's the whole point of a vaccine, is it provokes a response.
So that's the body responding to what you've been given, is it?
Yeah, exactly. That's the body responding, because the body's responding as if you're seeing a virus, even if you're not seeing a virus. So you get a little bit of a response. I can understand that, but I think I would look both at your own risk to yourself and the risk to society at large. So when you're talking about the flu vaccine, yes, plenty of people do that, and it might compromise it a little bit, but the results are maybe not as catastrophic as if people don't have this vaccine.
Yeah.
So this vaccine has such a high, this virus has such a high chance of killing people and particular vulnerable people that I'm going to have the vaccine for myself. I'm a middle-aged man now, so I'm higher risk than some categories. I'm not the highest risk, but I'm slightly higher. So I'm going to do it selfishly to protect me. I'm going to do it to protect my family, because I couldn't live with myself if I thought that I had, by not taking a vaccine, passed it on to, heaven forbid, my wife or my kids, and they'd become unwell. But I'm also going to do it for my patients and the people in my life that are high risk, who I want to see. My dad's been very unwell, for example, recently. I'm not sure he would make it through COVID. So if I didn't do it for myself, for selfish reasons, I think I'd do it to protect those that I love and those that I care for.
It's one of the things, isn't it, through the pandemic, about our behaviours have changed, often, yes, to protect ourselves, but often to protect others. That the use of masks is about protecting other people rather than ourselves. Right. So it's just an ongoing of that, isn't it? And hopefully long might, post-pandemic, our attitudes to each other, this care for each other, sort of be aware that our life has changed. So, let's not go back to normality. Let's go back to a better sort of world, really. This is the final question, Mark, because we've mentioned the flu vaccine, which you get every year to people that are vulnerable. Do you think COVID vaccine will be an annual thing, or is it too early to sort of talk in that sort of paradigm at the moment, that concept?
It's guesswork right now.
Right.
If you were to ask me to guess, and I'm not, I'm not usually a betting man, my guess would be that this will become an annual fixture, and you'll just get used to it. It's just part of life, like the rest of the vaccines you have through the rest of your life that you don't even think twice about. But we just don't quite know yet, and we don't know whether this will mutate with time and become more virulent or less virulent. Some viruses do that. Some viruses actually become less pathogenic. If it becomes less pathogenic, then we might not have to.
What does pathogenic mean, Mark?
Pathogenic, so causing disease, causing problems. So I think there's a lot of unknowns, and it's just a guess right now. But my guess would be that we're probably going to be looking at, this is another list of vaccines that we just add to everyday life.
Okay. So, Mark, I mean, I bet you didn't realise at the beginning of 2020 that you become a vaccinologist. That's a new thing to tell the grandchildren, isn't it? But if you 1 minute sum up the main points again of the news today with the vaccine study that you're involved in.
So the really great news today is that we now have 3 vaccines that work, and they work really well.
Mm-hmm.
And they're different, so they will be suitable for different populations of people. We're starting to really build a great army of different approaches to vaccinating, and it is likely that we are now in, and I'm sorry to incorrectly paraphrase Churchill, the beginning of the end of the pandemic rather than the end of the beginning.
Mm-hmm.
And so I'm really positive and really hopeful that life will return to normal next year, or a version of normal. Mm-hmm. And so you really just need to try to gird yourself and get through these next months, because better times are coming.